So in this video, you will understand that checking the spleen is very important, as you can spot different body abnormalities only by a single look at the spleen. Okay, so you need to know the difference. You need to know the normal splenic size and enhancement and location. Okay, so the size of the spleen shouldn't be less than 10 centimeter and shouldn't be more than 13 centimeter. This is the normal size. The normal location should be in the left hypochondrium. Okay, so what is the normal enhancement? The spleen is super. The spleen should be hyper enhancing, as you can see here. Okay, more than the liver. The spleen should be avidly enhancing. The spleen is super. Okay. So what about the normal splenic appearance on MRI T2-weighted image? The spleen is super in T2. The spleen should be the same signal of the liver or even brighter. It's not accepted to be darker. Okay, the spleen should be super to the liver in the T2 signal and in the enhancement. Okay, then let's start with the first abnormality of the spleen. As you can see here in this case, the spleen size is 8 centimeter. It is less than 10 centimeters. So the spleen here is shrunken, is decreased in size. Okay, so once you spotted a shrunken spleen, you need to check for his signal on T2-weighted image. You need to check for his signal on the T2-weighted image. For any small spleen, look at his signal on T2-weighted image. You need to check if this spleen is functioning or not. This spleen is very dark on T2-weighted image. This means splenic autoinfarction. Splenic autoinfarction. Okay. So here you check the spleen. It's very large. It's very large. Yes, the spleen is very large. It's more than 13 centimeter. This spleen is 14 centimeter. Okay, so we have here splenomegaly. What to do? What is the reason? Look at the liver. The liver is an indicator of splenic diseases. Look at the liver. Thus the liver is also enlarged. Okay. Look at the density of the liver. So if you look at the spleen, it's enlarged. Look at the liver. It's also enlarged. Look at the liver density. Okay. The liver density will solve this problem. If the liver density is if the liver is hypodense, how to know the liver if it is hypodense or hyperdense? Okay, on the post-contrast sequences, the liver density should be 60 Hausfeld unit, at least 60 Hausfeld unit, and shouldn't be more than 80 Hausfeld unit. So on post-contrast, let's type it here so you can remember. Normal liver density on post-contrast CT is between 60 and 80. Okay, shouldn't be less than 60, shouldn't be more than 80. So here the liver density, I've checked the liver density here, it's 50. Okay, it's 53 Hausfeld unit. This liver is hypodense. So what to do? This is hepatic steatosis. This is hepatic steatosis. So hepatic steatosis with hepatomegaly and splenomegaly is most likely to be due to venous congestion. Venous congestion, okay? Maybe due to portal vein compression, obstruction, hypertension. So you need to check for the portal vein. So you need to check for the portal vein. I've checked, I found splenic varices here, as you can see here. So, yes, the reason of the hepatosplenomegaly here is due to venous congestion. Okay, so in this case, we looked at the spleen. This is the normal. Okay, this is the normal splenic enhancement. So here, I looked at the spleen, normal size, normal size. However, abnormal enhancement. I mentioned before the spleen is super, should be hyper enhancing than the liver, should be hyper enhancing than the liver. The spleen here is hypo enhancing. Okay, so what to do? What is the reason of the hypo enhancing spleen? Look at the liver. Look at the liver. The liver is an indicator of splenic diseases. Okay, I've looked at the liver. What should I look at? Okay, I've looked at the liver and there are multiple peripheral hypodensities, multiple peripheral dense lesions. Some are wedge shaped. This is most likely hepatic infarcts. So the reason of the hypo enhancing spleen and the the peripheral located hypodense lesions in the liver is hypoperfusion. All of them hypo enhancing, hypodense. So it is hypoperfusion syndrome, most likely to be hypoperfusion syndrome or shock abdomen. Okay, here's a sign, a characteristic sign of hypoperfusion syndrome or shock abdomen. Okay, the slit IVC, slit-like IVC. Okay, don't miss this sign. Okay, and there's another sign, persistent enhancement of the kidney. Persistent enhancement of the kidney is another sign. The kidney is enhancing persistent. Its enhancing is persistent even in the delayed phase after 10 minutes. Okay. So you need to know that hypoperfusion syndrome could be due to hypotension, due to severe and prolonged hypotension. Okay, due to severe inflammatory process, and you need to check for these signs in acute pancreatitis. And it is a severe inflammatory process that leads to hypoperfusion, persistent and prolonged hypoperfusion of the body. Okay, so I've checked the spleen here. I found multiple hypodense nodules in the spleen. Okay, distributed diffusely through the spleen. Okay, so what is the reason of this lesion? Okay, this could be a sign of a multisystemic granulomatous disease. This is granulomas. These nodules are granulomatous disease. Okay, this is a part of multisystemic TB. So you need to check the lungs. You need to check the lungs for reactivation TB. So looking at the spleen, okay, will lead you to check the lung. Okay, this case is very interesting. Okay, now we checked the spleen, but we couldn't find any splenic tissue here. What should we do? We couldn't find any splenic tissue. Okay, look for the splenic tissue in any other sites. Okay, so yes, I found the super splenic tissue. Okay, in the left lower quadrant instead of the left hypochondrium. Okay, but there's something here. This is the splenic cyst. This is the characteristic appearance of the splenic cyst, okay? I just want your eye to be familiar with the appearance of the splenic cyst, okay? This is the spleen, this is the splenic cyst. Okay, so we checked the spleen, we couldn't find any splenic tissue, but we found it here. This is wandering spleen, wandering or ectopic spleen, okay? In this case, we checked the spleen. We checked the spleen, okay? But we couldn't find any splenic tissue. And we checked the spleen in the whole abdomen and the whole pelvis, and we couldn't find any splenic tissue, so there is no wandering spleen, okay? Then what we do? What should we do? You should look at the liver. You should look at the liver, okay? The liver is extremely enlarged, okay? When you see an enlarged liver, look at its density. Look at its density. The liver density here on the pre-contrast, CT is over 100 Hausfeld unit. 100 Hausfeld unit, okay? This liver is extremely hyperdense. The normal liver density should be in between 60 to 80. So shouldn't be more than 80 Hausfeld unit. Shouldn't be more than 80 Hausfeld unit on the post, not on the pre-contrast, on the post-contrast. When you give contrast to the liver, okay, this may increase the liver density, but not over 80. What about if the liver density without contrast over 100 Hausfeld unit? This is extremely hyperdense liver. This is not contrast. This is iron deposition, secondary hemochromatosis of repeated blood transfusion of thalassemia. This is a thalassemic patient. And of course, the spleen was extremely enlarged like the liver, but we surgically removed the spleen here and left the liver. So why I can't see the spleen here? The spleen, it is most likely that the spleen has been surgically removed, presumably because of massive splenomegaly of thalassemia. Okay, so the last case here, we checked the spleen. We couldn't find any single splenic tissue, but instead we found, sorry, go outside, please. Sorry, my kids. So we checked the spleen here. We couldn't find any single splenic tissue. Instead, we found multiple spleenules, multiple small spleenules in place of a single splenic tissue. So what to do? Okay, you need to check if this splenic tissue is functioning. So you need to check for their signal on the MRI T2 weighted image. You need to check for their signal on the MRI T2 weighted image, okay? So we've checked it, and it is of the same signal of the normal spleen. It is super to the liver. It is super to the liver. It is more brighter than the liver signal on T2-weighted image. So, okay, leave this patient. These are small spleenules, but they have the normal function. Okay, so we found that this patient have polysplenia. This patient has polysplenia. Okay, what to do? This patient has polysplenia. What to do? Then we need to look at two midline structures. Okay, not to leave the patient like this. So you need to look for other two midline structures. You need to look for the pancreas and for the duodenum. Don't worry, the other two midline structures are close to each other. So you want to go there and there, okay? Only here, check for the pancreas and the duodenum, okay? Okay. So this is the pancreas. What happened? The pancreas is congenitally shortened with no tail. Okay, this reflecting a semi-annular. The pancreas here wants to be semi-annular pancreas. Semi-annular pancreas. Okay. Then you need to check for the other midline structure, which is the duodenum. Okay, look at the duodenum here. What happened? The duodenum didn't go like this. Instead, it went like this. Okay, so this is the stomach. Okay, the first part, second part, which is the vertical part of the duodenum, and this is the third part. Okay, this is the second part of the duodenum, the vertical part, and this part, which is the third part of the duodenum, should be horizontal. No, the third part of the duodenum doesn't want to be horizontal. It wants to be vertical like this, okay? So the third part of the duodenum fails to cross the midline, and instead it's seen coursing to the right side or to the right upper quadrant. Coursing instead in the right upper quadrant. Okay, this is causing, or this have resulted in that all the small bowel loops to be located in the right side of the abdomen, and all the large bowel loops to be located in the left side of the abdomen. What is that called? This is called that the bowel loops is mal-rotated. They got malrotation. They didn't want to be here. All of the bowel loops wanted to be stuck here. Okay? They didn't want to be here with the large bowel loops. Okay? This is got malrotation. So, yes, I've spotted got malrotation. Don't leave the patient like this. Okay? You need to check for the development of volvulus in these small bowel loops. Check these malrotated small bowel loops for Evidence of volvulus development, small bowel volvulus. Okay, I don't know how to check for small bowel volvulus. Okay, I will show you a sign that you won't forget. This sign is the volvulus sign. It's the double beak sign. Double beak sign. Don't forget this sign. Double beak sign. Okay. Double beak sign. The small bowel or the first thing is that how to know that there is a volvulus. What is the difference between volvulus and the small bowel obstruction? Okay. We've got here proximal small bowel dilatation. Okay. But we have here two transition points or 2 points of obstruction. 2 points of obstruction. This is different from the small bowel obstruction that we have 2 points of obstruction. Okay. And after the level of the volvulus, we have collapsed distal collapse of the bowel loops. Okay, distally collapsed bowel loops, proximally dilated bowel loops, 2 points of obstruction or 2 transition points, cluster of dilated bowel loops in a radial orientation or a radial configuration, then a distally collapsed bowel loops. Okay, so the small bowel or jejunal loops are proximally dilated. Proximally dilated. Can you see the hostration of the bowel loops? That's why I've mentioned that the proximal jejunal loops are dilated. All of them are hostrated. Okay, all of them are hostrated. The proximally jejunal loops are dilated down to the level of an ileal loop, down to a segment of ileum, down to an ileal segment. Okay, where a transition point is noted. Where a transition point is noted. This means that the first transition point is noted. Okay, the first transition point leads to a cluster of dilated bowel loops in the lower central abdomen which show a radial configuration and seen best on the coronal. Okay, after this cluster of dilated loops, in a radial configuration, we've got another transition point, and that leads to a distally collapsed bowel loops. The two transition points of collapsed bowel, which led to the cluster, the two transition points which led to the cluster of dilated loops, are seen adjacent to each other, demonstrating double beak sign, which indicates tapered bowel at 2 points, obstructed bowel at 2 points, which indicates 2 points of obstruction. Okay, at 2 points of obstruction. This is characteristic of volvulus. Okay, so that's all. Just remember that. Who led you to the diagnosis of volvulus? The mid-gut malrotation. Who led you to the diagnosis of the mid-gut malrotation? And the semi-annular pancreas? Who led you to the mid-gut malrotation and semi-annular pancreas? The spleen. So that is the aim of this lecture, that the spleen led you to all of these diagnoses. The polysplenia led you to all of these diagnoses. So that's all, and thank you.